Welcome, everyone. I'm David Ridley. I want to thank our alumnus Kester Freeman for inspiring this interview and supporting this series. And I want to thank the many students who are joining us today. I especially want to thank our guest, Scott Heiser. Scott is the head of product strategy for Cityblock Health. Cityblock is a healthcare provider that focuses on marginalized patients with complex needs. Previously, he worked for a commercial insurer, and before that, he worked for Medicare and Medicaid on accountable care organizations. Welcome, Scott.
Thanks, David.
Scott, we plan to record this today. Is that all right with you?
It is. Just one note that I'm speaking, for myself and not on behalf of my organization.
Understood. Speaking of your organization, what is your organization? What is Cityblock Health?
Yeah, so Cityblock is a provider of integrated primary behavioral and social care. And so we contract with payers to basically take full risk on the health outcomes of Medicaid and dually eligible folks across the United States. We perform both in-person and technology-driven virtual care using teams that include what we call community health partners. And these are lay members of the community in which our members reside. Apologies, I have a canine visitor. So we use this team-based care to try to solve a much more expansive set of problems than you'll try to find solved in a traditional PCP setting. And so this is kind of the founding theory of the company.
So you take full risk for Medicaid patients.
Yeah.
Does that mean if you can really dramatically reduce their costs, you make a margin? And is that how Cityblock makes money?
That's exactly right. So in insurance parlance, we set a benchmark using a medical loss ratio target, which means that the sort of plan sets a threshold by which the premium they are paid is evaluated against how much money they spend on medical claims. And that benchmark translates to our threshold by which we share in all of the gains or actually are exposed to all the losses. And so we're able to use the funding mechanism there to invest much more expansively across integrated primary, behavioral, and social care. And that's kind of how we are able to generate savings.
So in your previous life, you worked on accountable care organizations, and those benchmarks, those thresholds also seem to be critical. It seems like setting those are critical. Can you tell us more about where the benchmark, where the threshold comes in? So you're told if you can get under this amount, you can make money. And do you have double-sided risk? So if you come in over, you lose money?
That's right.
And so how that benchmark is everything. So can you say more about where that comes from for both Cityblock Health and then more broadly, say for accountable care organizations?
Yeah. So there's two sort of basic constructs that inform how you set the benchmark. The first way that is the original way that ACO benchmarks and even organizations like Cityblock would be benchmarked is we take the cost for members that are attributed in a historical baseline period. So the actual cost, the actual spending for those people, we trend it forward, and then we compare did costs in the performance year among the people that are attributed in that year look better or worse than that benchmark. And the reason why that's advantageous and why people we're able to induce participation among a lot of organizations using that method is you have a lot of waste in your historical baseline period, have just a lot of unmanaged people. There's an opportunity to compress that spending and then share in the savings over time. The problem is that as you do that effectively, you sort of induce what we call a death ratchet to the benchmarking methodology, so that effectively I pay back in a future year all the savings that I had accrued in that past year, and it sort of tends towards zero. So the other mechanism, and this is more common in how Cityblock tends to contract, is using a kind of regionally derived target. So in Medicare Advantage or Medicaid or other payment lines of business, there's a premium that's set that's derived from either the expenses across a broader pool of people that include, but are not exclusively including, the people who are attributed to that organization. And so if our benchmark is $1,000 across the region, but the people that are attributed to us, we end up having costs in the, say, 800 range. We share in the difference in that $200 difference. And the next year, our benchmark won't be 800, but it'll be closer to 1,000 because it's again based on the experience of a broader pool of a reference population.
Just one or two more questions down in the weeds, then I'll get to some more interesting questions. So if I understand you correctly, the problem is you help those patients do well this year and next year, and your threshold would come down. And so it'd be really hard for you to make money because you've done such a great job in the past. And so instead of basing on that patient, you base it on a broader region. How broad is that region?
So there are many ways of constructing that regional target. Some are really just at the county level. So in Medicare Advantage, it's a weighted, typically it would be a weighted average of where your beneficiaries live compared to the county level rate book of where all of those folks are. And then the percentage of premium or the MLR target that you agree to with the payer would reflect all of those different rates across, like, let's say we have people who live in 5 different counties. There's 5 different CMS calculated premium values based on the fee-for-service costs that are in that area. And then also important is risk adjustment, which adjusts payments for the relative health status of people compared to the average person in that rate cell.
Okay, this is fascinating for me and super important for our future, I think, because so much of rewarding providers for improving patient health is going to be based on their ability to create savings for themselves, for the patients, for the payers. And so these benchmarks are critical. So thanks for that deep dive.
Yep. Benchmarks are super weedsy, but all important in payment reform. So I'm happy to go all day on this.
Good, thank you. So how do you get those costs down then? And a related question is, can you change behavior? It seems really, I know that I need to lose some pounds, but it's really hard to get me to change my behavior. It's really hard to get anybody to change their behavior. How can you bring those costs down? How can you change behavior?
Yeah. So a key feature of how Cityblock approaches this problem is we think that the integration of all of these different parts of the patient need, so that we have kind of a way of solving multiple different problems that they probably wouldn't be able to accomplish in a traditional office visit, allows us to have a broader surface area by which we can help patients change their behavior. And the way that we do that is really via that financial mechanism we were talking about. So because we believe, I mean, we've seen some evidence for this, that when we have a full risk benchmark across the total cost of care, which includes acute inpatient care, pharmacy sometimes, obviously professional and outpatient care across the entire total cost of care. If we overinvest in some places, we're able to effectively reduce the use of healthcare in other places. And so what that means is that, when we find a member who is socially isolated, for example, and needs investment in supportive housing or food insecurity or accompaniment, and we're able to break the cycle like utilization where they have, for lack of ability to connect with the rest of society, they're using the healthcare delivery system in an efficient way. What we've seen is we're able to impact how they use the delivery system by over investing in things that wouldn't be traditionally available to them. And it results in more stability in their conditions, and we benefit from that as well via the kind of full risk contracts that we hold. So an example, a real one, is we had a member who was experiencing about 10 to 15 ED and hospital admissions a quarter, and we through our team-based care with a member of our care team, the community health partner, were able to connect her to supportive housing, stabilize that trajectory, and her hospital admissions over the foregoing quarters went from 10 to 15 to 0. So, we see these kinds of archetypes where, depending on the chronicity or the kind of need the patient has, we're able to develop a strategy that effectively improves their health outcomes and that Cityblock benefits from.
Good. So helping people meet some basic human needs that are not necessarily healthcare needs by traditional definition, but help control healthcare costs.
That's right. And this is kind of the radical idea of Cityblock, which is that we're using this risk contracting architecture to re-engineer how we finance healthcare and what counts as a financeable event in healthcare. Whereas before, without a risk arrangement, this member can be cycling through the delivery system at a much more expensive clip, but certainly can't access supportive housing, can't access reliable meals. But with Cityblock's architecture in place, we're able to provide that to them.
So your model is focused on people who really need help with some of these basic human needs. Your model's focused on a Medicaid population. Do you have something to say about other populations, or does the model not easily translate?
So we definitely have members across other lines of businesses. So we care for members who are dually eligible, so they qualify for both Medicare and Medicaid. We do care for Medicare Advantage beneficiaries who are Medicare eligible folks who've chosen a private managed plan. In the future, we are likely to care for some fee-for-service Medicare patients with kind of a risk arrangement directly with CMS called direct contracting. We have a commercial line of business in one of our markets. And, of course, like the more states that we enter into, the more opportunity for us to think differently about, insurance coverage across those LOBs. I'd love to be in ACA. I'd love to be in employer-sponsored coverage where, we do see the density of need just the same. So it's not to say that like only in Medicaid is there a good Cityblock fit. It's across many coverage types.
My last question was about sort of scaling from Medicaid to other populations. What about scaling across cities? How many cities are you in now, and do you have plans for expansion?
Yeah, so we're today in 4 markets: New York, Connecticut, Massachusetts, and DC. This summer we'll be coming to North Carolina, and later Ohio. And we have a very, very ambitious goal of being able to serve 10 million members over the next 10 years. So we have 75,000 members today, so a little bit of room left to go. But that is the ambition, and that's one of the things that I go to sleep worrying about.
You mentioned earlier, you used the term layperson, that you rely on lay people.
Yeah.
Can you talk about your use of more traditional medical care providers versus less traditional, and why?
Yeah. So the community health partners are are part of the care team, but they are not clinically prepared. They they represent fully a third of all Cityblock employees. So they have impaneled patients just the same way as another clinician would. But what they do is not it's not like prescribing medications, right? It's accompaniment. It's helping solve social problems, connecting to resources. It's scheduling. It's becoming very acquainted with those patients and helping them solve problems. And then we also have obviously a deep staff of clinical folks that run the gamut of primary and behavioral specialties, as well as a contracted network in some markets where we work with other specialties. We also use virtual care to extend a bunch of specialties that our members need. And so part of what we do, because we have risk on this, is we have to curate providers that we want to work with and that help us effectively manage the risk across multiple different chronic illnesses and multiple different trajectories.
Can you talk about curating providers? So does that adding and subtracting providers that aren't getting the job done?
I mean, we don't necessarily subtract, but what we try and do is understand a network performance where, let's say we were to look at our members who receive hip replacements. We would want to know, of the facilities and surgeons that we see providing that procedure to our patients, which ones have higher rates of readmission, which ones are resulting in lots of complications. And we rely on our payer partners to deliver a comprehensive network of folks that can effectively meet the needs of our patients. But we obviously have an interest in ensuring that our members are seeing the best provider. And so it's not that we get to fire a provider from that network, but we do have influence over when that patient needs a procedure. We should care about where they go.
Scott, the next segment is overrated or underrated. I copied this from Tyler Cowen. I'll name an item and you can say whether it's overrated or underrated, and feel free to pass. Overrated or underrated commercial insurance?
Oh man, well, I would say this is a super loaded question, but very overrated in my opinion. If you know the story of why the U.S. has insurance through our employers in the United States, you would say, well, that's quite an accident. And to take 10 seconds on it, I mean, it's really an artifact of wage controls in World War II. And at the time that was probably okay because there wasn't a lot that healthcare could do for people. And so it didn't cost very much to insure folks. And it was a nice fringe benefit. But as we've seen innovation and technology grow into the kind of behemoth that American healthcare represents in our economy, what employer-sponsored coverage has created is a sort of hidden source of a lot of dysfunction in U.S. healthcare. First of all, that little tax subsidy that started in World War II has grown into the actually largest single tax subsidy we have, and it overwhelmingly benefits wealthy individuals. Second, it depresses wages a lot in this hidden way because employees don't really have a lot of visibility into the cost of carrying that coverage. And also because of the subsidy, employers aren't really cost pressured, so they're just passing that on in the form of not giving you a raise. And then third, I really dislike it because employers are exposed to the premium costs, but they're not really exposed to the sources that are driving that premium, which is in most commercial markets about provider consolidation. And so they aren't really well placed to attack that. And overall, I think this really does promote kind of a lack of systemness. and the lack of a consistent, way that we approach paying providers, in linking people to healthcare delivery, through this model of coverage. And I just don't think that's desirable. There are lots of places where, we see private coverage, as working pretty well. So Germany or Switzerland or Netherlands. But they fill in the holes a lot better. What they do is they have a single fee schedule across payers. They require you to carry coverage regardless of whether or not you have a job. They subsidize you if you can't afford coverage. And so all of those things, like, we have some parts here in the US, but not completely. And so overall, like, I would say this is actually not helping us move the needle across US healthcare. Sorry.
Scott, as with your other answers, that was a really smart, detailed answer. I want to dig in, as before, I want to dig into one of the details. You said Netherlands, Germany, single fee schedule.
Yeah.
Would you think that it would, instead of, so maybe an alternative to Medicare for all, maybe Medicare for all is a good option, but maybe an alternative to Medicare for all is Medicare fee schedule for all. Would you agree with that?
Yeah. So, like, in most, so gets back to this question of whether fee for service is evil. So fee for service is the dominant payment system in many different international systems. But the difference is that the fee schedules are often regulated by some central body. So it doesn't matter whether I get insurance from a sickness fund provided by my employer, as in Germany, or whether the German government subsidizes me to purchase it from a public plan. I know that per unit, I'm paying the same rate to a provider regardless of where I go. And that variation is not true in the US. Or rather, that in the US, like, there is a lot of variation that's derived from that difference. And I think that, all payer rate setting, would be an alternative to, necessarily, like, let's say, a public option, but it may not be quite as desirable, because some of the functionality that a public option might bring includes all of what we call the SG&A functions of an insurance plan, which can be done perhaps more cheaply by the federal government than compared to private plans just paying that rate. Though I would say a substantial contribution to at least some option there would certainly be all payer rate setting.
I hope no one across the street at Duke Health is listening to this conversation. They would not be very happy with Medicare pay schedule for all, but hopefully nobody over there is listening. That doesn't mean you're wrong, just means I hope they're not listening. So you spoke of you mentioned fee for service, and you said maybe that's good, maybe that's not good. An alternative to fee for service is capitation or accountable care organizations. So we talked earlier about accountable care organizations. You've got this threshold, this benchmark. If you come under, you make money. If you go over, this is from the provider's perspective. If the provider saves some money, they make some money. The provider goes over the threshold, they lose some money. Accountable care organizations so far haven't saved Medicare much money.
Yeah.
Are accountable care organizations overrated or underrated?
I'll take that in a second, but so I would say the important question around fee for service is it married with a governor on total cost of care? And it's a mode of reimbursing providers. It's not an end in and of itself. And so the reason why ACOs are powered by fee for service and why we think that still works is because there is a governor on the total cost of care, that benchmark. And people have, and in relation to the previous answer, people have observed that, prices are the problem in commercial insurance. And so if all you did is really focused on the unit cost variation, but you didn't have any control on total cost of care, you might actually end up worse. And an example of that is actually an all-payer rate setting experiment we have from Maryland, where in the 1970s, CMS agreed to give the state of Maryland a waiver from basically the Medicare fee schedule, and agreed to pay the same rate across all payers. And that waiver continued for 30 years. And at some point, CMS studied what was happening to its balance sheet in Maryland, and it discovered that utilization was the highest of anywhere in the country. So total spending, even though the unit cost was the lowest across payers, it actually was the highest total spending, because obviously what matters is not just the price, but also the quantity. And so, this concept of, if we only focus on one part of the equation, we won't get there, is why I think it's really important to think about ACOs, or risk contracting generally. And so that's why I would say ACOs are super underrated. And ACOs are really pursuing the same mechanism that Cityblock is. The first ACOs were founded in the mid 2000s as part of the physician group practice demonstration, and they were expanded as part of the ACA. And what they are trying to do is very similar, and they are trying to reduce spending against a benchmark, and they look at the entirety of total cost of care. And most of the successful ACOs have observed, well, really the source of the most variation in Medicare, where they were first expanded, is in post-acute care. So lots of unnecessary SNF use, lots of LTAC use. And these are really expensive places that can be delivered, services that can be delivered more safely, even at home. If we just change that one little behavior, we can save the government a lot of money, and we can keep a lot of the difference. And so getting back to the question of fee for service, it doesn't much matter to me whether or not we pay providers using fee for service, or whether we give them capitated payments. That's really a cash flow mechanism. What matters is, do we have a way to measure the performance such that the improvement against that benchmark is really translating to, the better you do, the more you take home. Whereas in fee for service without a governor, what that means is, the more I do, the more I take home. And that's really the wrong and more perverse incentive. And I guess I would just say, to close on ACOs, like, ACOs are the most successful payment reform ever. We've tried a lot of things in this world, and nothing has saved the government money while improving quality and improving patient experience, while ACOs have. The reason why people are critical of ACOs is that I think they were speaking to a misplaced expectation that we have so much waste in healthcare. If we just create a financial incentive for organizations, we'll just wring it out all overnight. And I don't think that's really a realistic way to think about it. And the point that I would close on is just that we don't need home runs in U.S. healthcare to make significant dents, or even to bring spending to a level that we actually restore health to the Medicare trust funds or help consumers. We need to slow the rate of growth. So we need a lot more singles. We don't need home runs. And ACOs are at least a solid single, and I would even say maybe even double.
So great, Scott. So 3 follow-up items. Number one, I was suggesting that ACOs replace fee for service, but you made the important point. Fee for service doesn't go away. It's still underlying the ACO model. That's still how the providers are going to get paid. But the ACO provides what you call a governor. You don't mean like a state governor. You mean some sort of constraint on overall spending.
That's right.
Second follow-up, the health economist Uwe Reinhardt famously said, "It's the prices, stupid. The reason U.S. healthcare spending is so high is because our prices are so high." But what I hear you saying, it's the overall spending, stupid, because even if you bring down prices, you could get quantities going up and have no effect on spending.
Yeah. So it depends on which market you're talking about. So Uwe's point is deeply true in commercial markets, where it's really not that Americans are using a lot more healthcare compared to other places. It's that we pay so much more per unit. And so a strategy that doesn't address unit costs in commercial markets isn't going to be effective. But in Medicare, it's actually the reverse. There's one rate that Medicare pays, and this is often true in Medicaid. You know, the price is the same, but the utilization is wrong. And so you need both strategies, and you need both a financial theory of the case as well as a clinical theory of the case to be able to do both.
Another point you made earlier was that we need to stop looking for home runs. I think there are a lot of outsiders that have heard over and over. Warren Buffett heard, healthcare is broken, healthcare is stupid, healthcare is a parasite in the American economy. I, a smart rich guy, can fix all this. I'm going to create Haven along with some other smart rich guys.
Yeah.
I think these arrogant outsiders hear this narrative over and over again, and they think home runs are easy, but we really shouldn't overlook the value of singles and doubles and declare ACOs a failure because they weren't home runs.
That's right. So, you know, the classic statistic that people cite around waste in healthcare is, 30% of the healthcare dollar is wasted. And so, our original experiments in trying to change how we paid providers, which included ACOs, which included bundles, which included state-based reforms, they were hoping to address all 30%, right? And it just wasn't realistic to believe that we would be able to construct a payment arrangement, and then the political will, the organizational will, the know-how, the energy would be able to wring out that amount overnight. And I also think that we also misunderstood what our actual target was. It is okay if Americans decide to spend more than France or the UK does on healthcare as a percentage of our economy. And in fact, there are many countries that do. What we can't afford to do is continue to spend as much as we are spending and continue to get such poor outcomes out of that spending. And if we are able to slow the rate of growth, and maybe even in a dream world, actually reduce the rate of growth to a negative number, we'll get a lot closer to those international peers. But I don't personally think that we should be orienting around home runs. I will take singles and doubles all day, because the goal is to score runs and win the game. It's not to have an adoring crowd of people.
By the way, for those of you who aren't in Japan or parts of Asia or North America, we're referring to a game called baseball. Actually, and for those of you who aren't over the age of 40 or whatever, I don't know how old you are, Scott, but I'm afraid people under 40 outside North America and parts of Asia don't know what game we're talking about here. It's a game that's kind of like cricket and equally boring for those of you that are unfamiliar. Final. What's that, Scott?
A lot of math.
A lot of math. Yes, it's good for math. It's a good sport for math geeks. And gave us Moneyball, which has been used in several sports now. Final overrated, underrated question, Scott. Overrated or underrated? Medicaid.
Hugely, hugely underrated. There was a study that last year, building on a lot of the research that we saw in Oregon when there was a lottery that expanded Medicaid, but studied the national Medicaid expansions, and found that there was a 9% reduction in the mortality rate directly attributable to the expansion of the program, which you may know, we do not yet have here in North Carolina. And, basically that's an incredible effect size. You never see this large of an effect size on mortality, which is one of the toughest things to detect impacts around. And so there's something about having access to robust insurance coverage that enables people in this strata of society to gain access to effective treatment that really directly avoids preventable deaths and disability. In the building in which I used to go into sometimes at HHS, there's a great quote by Hubert Humphrey, who is responsible for much of the creation of what became HHS. And the quote is, "It was once said that the moral test of government is how the government treats those who are at the dawn of life, the children, those who are in the twilight of life, the elderly, and those who are in the shadows of life, the sick, the needy, and the handicapped." And almost every one of those populations are affected by Medicaid. So, I think it is a hugely underrated program, and, it's very important that we work to protect and expand it.
That was powerful. Thank you, Scott.